Good morning, good afternoon, and good evening, everyone. I hope everyone can hear me. I would like to extend a warm welcome to everyone attending this webinar on epidemiology of COVID-19 and risk communication approaches. I'm Sabina Sigdel, and I, along with Dr. Karma Tenjing, will be moderating today's webinar. So this webinar is being hosted by One Health Knowledge Cafe, which is a collaborative effort of more than 11 individuals representing CIH partners and alumni. And the members are from Asia, Africa, Europe, South America, and North America. This aims to bring together the expertise and network of researchers and professionals from various discipline, countries, and expertise to enable cross-learning, sharing, and network building. So it has been organizing many webinars, and it is supported by LMU CIS through that exit program funded by BMZ. So here are a few housekeeping rules. I request everyone to keep yourself muted unless you are speaking, and keep your videos off if you are not presenting. And the session will be recorded and shared, and a PowerPoint slide will also be made available in our CIH website. So we will have Q&A session at end of all the presentation. So any specific questions to a particular presenter, just for clarification, is limited to 2 minutes for 2 questions. So we have altogether 3 presentations, and each presentation will be of 10 to 12 minutes. Our speakers are Dr. Guru Prasad Dakal, Dr. Cristobal Kinio, and Dr. Taufik Joder. And after all the presentation, we have Q&A and discussion session, and we have allocated 30 minutes for the Q&A and discussion session. I'm pleased to introduce our first speaker for this webinar. He is Dr. Guru Prasad Dakal. He is a gastroenterologist and head of Department of Medicine at Jigme Dorji Wanchuk National Referral Hospital, and he's also an associate professor under Khesar Galpo University of Medicine Science, Bhutan in Thimphu. He is also serving as a chairman in various committees and also the member of Doctors of Special Assignment for COVID Management in Bhutan. He also received National Order of Merit in Teaching from His Majesty, the King of Bhutan in 2016. So I hand over the floor to Dr. Guru for his presentation. Over to you, Dr. Guru. You can share your screen now. So, yeah.
Thank you, Sabina, for that wonderful introduction. At the outset, I would like to thank the organizers for giving me this opportunity to talk on the epidemiology of COVID-19 and risk communication approaches. Many of you must be wondering what this gastroenterologist is doing here in the, the webinar for COVID-19. But I had the opportunity to be the member of the Doctor on Special Assignment for COVID Management in Bhutan, and I have also managing most of the COVID-19 cases that have been that have come to Bhutan so far. So it's actually a great privilege and honor for me to be a part of this August webinar today. In the beginning, when I accepted the job of presenting today, I wanted to find out what does epidemiology really mean and how I should go about with my presentation. So when I looked at the dictionary of epidemiology by Last, the page 62 describes epidemiology as the study, the distribution, and determinants, the 3 things which we really need to include in my presentation. But with limited time that was given to me and the the complexity of COVID-19 disease, I found that it was difficult to cover all these aspects. Study basically in epidemiology also means the experiments, the hypothesis testing, the analytical studies, so which practically was not possible. When it comes to distribution, the dictionary tells it is related to time, place, person, and the affected population. The determinants deals with the social, cultural, physical, and biological aspects of the health-related state. So considering the limited time and the complexity of changing in determinants and various aspects, when I went through the literature that is available, I decided that I will limit my presentation to the global scenario of COVID-19 disease, which basically I'll be talking from the weekly epidemiological report from WHO and CDC, the scenario of COVID-19 in Southeast Asian region in very brief, and what is the status of COVID-19 in Bhutan so far. And when it comes to risk communication, I'll be talking mostly about its importance, the approaches and the approaches that we have implemented in Bhutan's context. To start with, actually, the outbreaks have been part of humanity since we existed. We have battled various epidemics, endemics, and the natural disasters. And these epidemics and endemics will continue to, affect us in future. Some of the epidemics and endemics that we can go through the history are that of the endemic plague, the cholera, the influenza pandemics, so long and so forth. But it is probably not the last that we are dealing with. Now, to go back to COVID-19, we all know that it was first reported in December 2019 as unknown pneumonia from China. After that, Thailand was the first country to report the disease outside China. That was done on 11 January 2020. And WHO declared this as a public health emergency of international concern in January 2020 and as pandemic on 11th March 2020. After that, if we look at the global scenario, this is the report from the latest WHO weekly surveillance report. We can see that starting from March 2020, the yellow is the American region, purple is the Southeast Asia region, and the Europe and Mediterranean. You can see that the number of cases have been steadily increasing. Two very big peaks, one between September to January 2021, and another peak started from 12th April till 14th January. Most of the cases during this time has been contributed by the Americas. If we look at the bars by Americas and the Southeast Asia, with very less contribution or relatively lesser contribution from Eastern Mediterranean, Western Pacific, and the African region. If we look at the deaths, we can see that at the beginning of the pandemic, there was one peak of deaths, and expected so because we were least prepared to deal with it. After that, it has plateaued, and as the number of cases peaked, the deaths also peaked between December to March and from April to June this year. In absolute number, we can see that so far, more than 177 million cases have been reported. Of these, weekly, in the last 1 week, there were 2.5 million cases reported globally. But good news is that there has been a decline or decrease by 6% compared to the previous week. The total number of deaths reported in last 1 week was 64,000. And again, very heartening to see that there was a decrease by 12%. When it look by region-wise, the Americas and Western Pacific region have the same number of cases that were reported the previous week, which means the case had neither increased nor decreased. But our region, Southeast Asia region, and the European regions have reported the decline in cases. Unfortunately, the African region has recorded marked increase in number of cases, weekly cases. it was almost increased by 39%, and the deaths by about 38%. Now, what are the different variants? It is important to know the variants, because as the variants change, the clinical implications, managerial implications, and the preventive implications also change. Globally, the 170 countries has reported alpha as the predominant variant. Beta variant was predominant in 119 countries. 71 countries had gamma, and 85 countries had delta variants. Now, recently, our region, especially India, has reported delta plus variant, which has not been reported as yet. But now, looking at the number of cases in Southeast Asia region, we have seen that it also has two peaks. It coincided with the global peak. First peak in July to November last year, and another peak that's going on now from March till June. Now, in absolute numbers, last 1 week, Southeast Asia region has reported 600,000 new cases, and this was a fall by 21% compared to last week, and 19,000 deaths, which was a decrease of death by 26%. The countries which have reported maximum number of cases were India, Indonesia, and Bangladesh, and highest number of deaths were also reported from these three countries. Now, what about Bhutan? To many of you who do not know where Bhutan is located, we are bordered on the north by China. In the south, we have south, east, and west, we are bordered by India, and small country located between two giants. And we reported the first COVID-19 case on 6th of March 2020. He was a tourist who came, American tourist who came to Bhutan via London, India, and then when he reached Bhutan, we detected as the first case. Now, looking at the total number of cases, I apologize for the slide being not very clear, but we can see that the first case was reported in March, and then we didn't have the real surge, and then we can see that there are peaks, two peaks. These actually are not the community outbreaks, because once there were an increase in number of cases in the outside world, many of the Bhutanese who were working in other countries have returned to Bhutan. And when they came to Bhutan, we detected that they were COVID positive, so number of cases have increased. So almost for a month, we had just 1 or 2 cases. The second peak is again the number of cases that were returning from abroad. And this steep increase in rise was because there was a small community outbreak. This was of 2020. And this continued in January 2021. The number of cases came down. And again, there are small community outbreaks going on in Bhutan, and there are increasing number of cases. Now, one interesting thing about Bhutan is probably why we didn't have the community outbreaks is, for example, these cases who came from abroad, I'm talking of slide in 2020, anybody who comes from abroad are kept on facility-based quarantine or isolation, whatever. If the cases are positive, they are kept in facility-based quarantine. We have no system of home quarantine. So only when they are COVID-19 for a period of 3 weeks, and only when somebody tests COVID-19 at the end of the quarantine or isolation, the cases are allowed to mix to the community. So this is one innovation which Bhutan has taken, and we can realize that this has prevented the community outbreaks. A few of these community, and the other reason why we have number of cases, I mean, our cases coming here is the people who have gone abroad for medical treatment. When they come back, many of them turn out to be positive, and they have contributed to the number of cases, and these are not the community outbreaks. Now, as of 23rd June, Bhutan has reported 1,970 cases, of which majority were males. 1,249 were males and 721 were female. We have 267 active cases now, recovered 1,702, and we have had only 1 COVID death so far. The community outbreak, small community outbreak that is occurring now are in the southern border, which are bordering India. So if you look at the map again, the present community outbreak, present community outbreak are in this southern belt, which is bordering India, and this eastern belt, which is again bordering India. In summary, now globally, we have had more than 177 million cases. Both the new cases and deaths are declining compared to previous week, except in the African region where the number of cases are increasing. In our region, India and Bangladesh and Indonesia have contributed largest number of deaths and the cases in last 1 week. Bhutan has reported very small community outbreak so far, hadn't had the nationwide outbreak. When it comes to variant, the predominant variant is globally is 177 alpha, which has affected 177 countries. But a recent study in Bhutan has revealed that the present outbreak is because of the Delta variant. This is all about the epidemiology. And now when it comes to risk communication, risk communication actually, what is its importance is that risk communication does not prevent risk, or it doesn't stop it completely. It just means that approaching the risks and problems systematically and carefully so that the damage is minimized. Now, why is the risk communication so important these days? Is that COVID-19 has not only revealed that it is only a health crisis or an economic crisis, which has really affected the economy and it has impacted the economy, but it has also created the information crisis. So how do we respond to this pandemic depends upon how the people behave, how the social norm, and unless we address this, the transmission is going to continue. So until we have the effective vaccines or treatments available, the people's behavior and their willingness to follow the public health measures, social measures will remain the most important and powerful weapon to prevent transmission and reduce the impact of the pandemic. Therefore, the importance of risk communication is very, very unprecedented at this time. The other thing is the people have become complacent, and the people have started feeling that the COVID-19 is, not as serious or not as important as it used to be. The other important reason why we need to have the risk communication is now the pandemic fatigue is setting. People have the pandemic is prolonging too long, and the fatigue has set in. Therefore, the risk communication will play a very important role in breaking the chain of transmission and mitigating the impact of pandemic. CDC, in one of its publications, has rightly said that the right message at the right time from the right person can save lives. So risk communication, the importance of risk communication through right person and right message, and what message we are conveying and how we convey is also equally important. So based on this, WHO has first published its COVID-19 global risk communication guide and communication and community management guideline in March 2020, and it has revised in December 2020 to May 2021. So what are the different approaches that we have for this is, the approach should be people-centered and community-led approaches. If it is people-centered and community-led, it will increase the trust and social cohesion, and it will reduce the negative impacts of the pandemic. What are the strategic objectives as per WHO for the risk communication and community engagement? There are 4 more objectives. One is community-led. The second objective is data-driven. It should be data-driven. It should be collaborative, and it should reinforce capacity, and local solutions. So how has Bhutan really adopted this, or how have this objective been followed, is that uh, most of the COVID management, in the sense the risk communication uh, uh, task is taken by the community themselves. It is just that the central, we have the task force, what we call the task force for COVID management. We have the central level task force, we have the district level task force, and we have the sub-district level task force. So most of the activities on risk communication are taken care by the sub-district task force, but it is facilitated by the district and central task force. The central task force actually does not directly uh, indulge with the sub-district task force, but wherever they need a technical support, or wherever they lack in the capacity, it is just facilitated by the other task forces. This is basically to maintain the quality and consistency of the risk communication. Data driven, I think Bhutan has one of the strongest data driven um, risk communication approach. We have the online application which helps in tracing the contacts, so that as soon as a case becomes positive, we can trace this, keep on isolation. If they are positive, the contacts are put on quarantine. The other thing is the survey that we periodically carry away about the mask use, the hand hygiene, actually help us to tell the community that certain community hasn't been following properly or has been complacent. So the central task force usually carries the surveys, and then the sub task force are informed about the survey, and based on this, the risk communications are reinforced. Now, third is the collaborative. Um Basically, this is the coordination. So it is not that only health is doing this risk communication approach. There are the non-health departments, or the people who also help the health department. So it's a collaborative. And basically, the local solutions are reinforced by the central task force, rather than the central task force implementing the risk communications. So it is not actually, in the beginning, it used to be more of a directive telling that the central task force will tell the local task force about what they should do. Now it is more of two-way communication. The local task force and the central task force, they work together, and they come to the activities and the solutions that has to be implemented. Now, what are the principles that are being followed? These are the same principles which are guided by WHO, nationally led, in the sense, Bhutan is very happy to announce that His Majesty himself, the King himself, has been very actively leading the risk communication approaches, visiting the remotest part of the country, and then sensitizing the people about the importance of prevention. So not only that, the Prime Minister himself, being a medical person, has been actively involved, so that the leadership in Bhutan has been very, very strong, and the political commitment to fight this pandemic has been very strong. It is mostly community centered, as I said. It used to be in the beginning more of a directive one, but now it is community centered. The activities are implemented by the community. The activities are decided by the community. Of course, because they don't have the full capacity, it is facilitated by the center and people who are really good at it. It's participatory. Most of the community people participate on it. It's on trust building. Innovative in the sense, like Bhutan is, I think, only country where the quarantine, any person who comes out of the country is kept in quarantine for 3 months. And even innovative in the sense of risk communication approaches, involving the community themselves and the community leaders to disseminate the message to the community, so that people become more proactive and they receive the message well. On by data, because periodical surveys are carried out about where we are lacking on the risk communication, starting from the surveys on the use of masks and the hand hygiene practice by the people, about social distancing. So wherever there is a deficiency, these are reinforced, integrated and coordinated, because we don't really have only health sector working on it. There are different sectors and NGOs who are also helping in risk communication. All classes of people in the societies are included in the risk communication, and people are accountable. We are accountable to whatever we do to the community. So in summary, the risk communication in Bhutan has been people-centered, and it is a community-led approach. And so far, it has been very impactful. It is national-led, highest level of commitment from His Majesty the King to Prime Minister and all politicians and the local leaders, centered on the community, integrated, involving different sectors, and innovative, which probably help in making this risk communication approach very efficient. Thank you. And these are the references that I have used for my presentation.
Thank you so much, Dr. Guru, for your very informative presentation on epidemiology and risk communication approaches in context of Bhutan. That was really helpful. For the audiences, if you have any questions for Dr. Guru, you can post it in the chat box. We will address it in the Q&A sessions. So we move on to the second presentation. It's my honor to introduce our second speaker, Dr. Cristobal Quiniano. He obtained his PhD in applied mathematics and is working as a member of the mathematical neuroscience at the Collège de France. In March 2017, he became an assistant professor at the Institute of Engineering Science. His research is mainly related to mathematical questions arising from biological systems that combine different techniques of functional analysis, equation in partial derivatives, and stochastic systems. So I hand over the floor to Dr. Christopher. Over to you.
Thanks a lot, Sabina, and I'm very pleased to be. Very pleased to be here, and thanks for the organizers and the opportunity to show you some of the work we have been doing. I'm gonna shut down the video in order to share you the slides. So give me a second. And stop broadcast. You should be seeing, yeah, there we have. So what I'm going to talk to you today is I'm from a different background than the first speaker. I'm a mathematician, so I work on equation and I try to analyze the data. So what I'm going to show you is some of the work we have been doing in analyzing the European data, and then we are going to move on to my local community, which is I would say a town that is a little bit more than a town. It's a region called O'Higgins, and I'm going to show you where it's located in the next slides. So as I said to you, first I'm going to analyze a little bit of the available data of Europe, and just for completitude, some of the things that we do know, and thanks to the first presentation, we know better, is that actually coronavirus is a disease that started in 2019, and we are in the middle of 2021, and we're still having some various issues with the disease, especially in southern countries, as we will see later. It was declared a public health emergency in January 2020, and at the day we have a lot of people getting the disease, well, 145 million, and a lot of them are dead already. So it's really threatened, and it's a risk. And if we do not have a nice approach in the communication, we will have a lot of problems in the future. And that's some of the things that I want to share you today. So what can we do? There's a lot of data available, and we know from the first speaker that analyzing the data in a multidisciplinary context, it would be a very nice idea, because it gives you some of different thoughts and perspectives of this disease. And what we started to do a couple of months ago was just take some of the countries that have a very similar first wave, as you can see here, they all start at somehow the same weeks, and very similar, also comparable testing approaches. So both of those 6 cases that you can see here in the small letter, which is France, Belgium, Germany, Italy, Spain, and United Kingdom, at the very first beginning, they behave very similar. So what we're trying to do here is to compare the waves that we could see in the past, in order to see what was going on in the first semester of this year until April 17th. So what about mathematics and this sort of course? We can say that any disease, virus disease, it's very similar to the biological mechanism of replication inside the body, which means that the rate of the spread of the disease is very proportional to the number of cells that got in the disease. And in a population approach, you are saying that the number of the rate of the increasing of the number of people that have gotten the disease is proportional to the number of people that actually can transmit the disease. So this is a very simplistic model, but actually tells you a very nice story, if you can say. If you take this approach and use some basic mathematics, you will see that actually the number of cases, which is here denoted by NI, the number of cases, of active cases in any country, can be studied as the number of cases in a certain period of time times the exponential of the growth rate of the disease. And that is something related with some of the things that we have already listened in the press, which is it's related, it's not directly the R number, but it's closely related to it. And if you take the logarithm, you will find some equation of this type. What is important of this equation is that if you look at closely, you will see that this, if you write it down like y, you will say y0 plus something. So it's very close to a linear trend in a very small amount of time. And that is what you call an exponential model. I'm going fast because I want to show you the curves, which are much more important than the equations that I will show you today. So what you can see if you look it down, this equation is that if you, for a moment, say for a very short period of time, for example, day 1 to day 4, the curves are really close to align in this approach. And for if you have data of this sort, anyone who has working with some basic statistics would say that, okay, if I have that, I can find the best line that actually represents the dots. And that is called the linear regression problem. If you do that on successive delta times, you will find some lines that actually matches very close to the curves. But those curves are much more interesting than the data itself. The data, and here you can see, and you can answer a first question, can a mathematical model reproduce the pandemic curve in the past? Actually, it does. It can do it. And this simplistic approach allows you to understand much better the curve, because in the very first beginning, you only have this stuff like showing that you can see as peaks of the disease. But how can you say, okay, here started the wave and here ended the wave? That is not a very easy question to answer. But if you plot the data in a logarithm scale, you will see that actually is much nicer to understand, because if you now compute the derivative of these curves, you will find that the derivative on this graph is actually somehow measuring the speed of growing or decreasing of the disease in any of the constants that you see. And if you see that if your derivative is larger than, if your derivative is positive, absolutely you are saying that the disease is increasing, the virus is increasing inside the population, so you will end up in some of this part of the curve. And if your derivative is negative, which you can see here or here, then you are in the downside of the wave. Much over, you can say if your derivative is larger than one, then you are saying that this stuff is larger than one, and you're saying that if you have one people sick, then you have more than one people in the next stage of the time. So one is a very interesting number here. And if you plot down, if you compute the derivative and see the time frames where the derivative is larger than one or smaller than minus one, you will see that you can actually define the waves in any of the countries. And here you have some very interesting stuff that you can see. If you compare the first wave with this approach with the second wave, you will see that the first one is very short, but it has a it's a very important increase in the very first part of all of the waves. And then you have a short period of time where this is going down, and somehow you see that the curve is steady, but sometimes it goes up again, and this is what you call the second wave. When it goes up again, it's very difficult to flatten it, and you will see that it started to grow. It has some upwards and downwards, and somehow you have to wait a longer period of time in order to go back to a flattened curve, if you want to say so. So what's happened here? Why those two curves are different? We can have some conjectures, but we cannot say for sure what's going on. There are other approaches to mathematical understanding of these curves. You can use the SEER model, which for any epidemiologist is very well known. When you have the whole population, you say you can have a portion of the population that can get the disease, a portion of the population which is infected, a portion of the population which is recovered, which is the acronym SEER. But you can also use a stochastic simulation, but with a simplistic model, you can say a lot of things. That's what I want to say to you in this slide. Then, when you realize that this number, you can compute this number from the data, and then you can have a very nice approximation of this derivative. And here's when the things is much more interesting. You will see that here I have this graph is for the derivative. So it's telling you if this derivative is larger than one, then you have an overexpansion of the disease in each of the countries. It is negative, you have a contraction. But you can see when you have an increase, it's always larger than the period of time and the amount of time that it decreases. So much of the first wave should behave like something which is going up, and then going down much slower. So you have something which should be something like that. And in the second wave, you can see some curves going up, going down, going up, going down, going down, but never going absolutely down to negative. So you have always some disease that is increasing. At some point, it goes over one, and then you have a huge peak, and then a smaller decrease. And you can see the same in any of the curves. If you see, here's the green, you have a larger, and then you're going down. So at the end, you will have some of the first question you can answer. You can actually see a first wave and define some time frames where it's absolutely happening. But you have a second very interesting thing that you can see here is that you will always have, at least in these 6 countries, a small period of time when you think that you have a wave, but it's like a pre-wave, and then it goes up absolutely like that. If you come back to the data, here you can see that, for example, in the green curve, what you can expect is having a first wave very well defined. You can see here a huge increasing and then a very slow decrease, then a flat curve. Then you have something which is what I like to call a pre-wave. And somehow it decreases, you think, okay, everything is going right, we can relax, and there's where the risk communication takes place, because if you do that, you have later a huge going up. Then you have a go down, then think, okay, everything is going right, you release the population, you relax from the risk self-care, and somehow you have a pre, and then once again, this is Spain. And but you can see the same in all of the curves. For example, here you have a pre-wave here, and then a truly wave there. So what it's telling us is that for any country which is starting to see an increase of the number of cases followed by a small decrease, then the thing is not all over, and you have to be careful because you might be at the beginning of a huge wave, which is much more disastrous than the first one. Okay, so if you take all of that information, you can have some of the dynamics of the waves. First, the initial waves have a sharp initial growth and a subsequent normalization. The sharp initial growth is very strong, and the normalization takes much more time. And the second wave have like a more slower initial growth. It has going up, going down in the time derivative of this curve. These fluctuations at some point become relevant, and then you have an actual second wave. Yeah, so the thing is that these fluctuations are so rapid that you cannot actually take a second and third wave, and in this approach you have all the second and the third wave all of the sudden. Why this might be happening, measures taken by single governments and communication approaches. If you see the mortality, you will see that in the first weeks of the first wave, we have a larger number of cases, but since the second wave is much larger in time, you'll have at the end in between 2 and 4 times the death of the first wave. So the second wave is very worrying for any country who hasn't already got into the second wave should be very worried about that. Should take in measures. But a very nice question is that if you look at the data and the number of tests, you'll see that the very first part of the disease, most of the countries were taking very few cases, very few tests. So we wonder if the second wave is actually a true second wave or an effect of having more tests. That is some of the things that you expect. If you have more tests, you would expect to have more cases. So maybe it's not an effect of a truly second wave, but it's an effect of having more tests in the population. So we normalized the data, which is can be found easily on the website that I presented you at the very first beginning of the talk. And you will see that, for example, in Belgium, which is the brown curve here, we have a first wave that have a positivity of 30% of the test at the period of time. But if you see the second wave, you have pretty much the same positivity. So you have ways that actually happened. It is not an artifact of having more tests. And there are countries like Spain. If you see at the very first beginning, you cannot say much because you don't have enough tests. So you might be not well understanding what's going on, but as soon as you see an increase, the positivity increase and maintains, slow a little bit and increase again. So again, you have a pre-wave and then a truly wave that is much more longer in time. And this happened for pretty much all of the curves, as you can see here. And a second analysis that we can make is that in the first wave, there might be an underestimation of the severity of the disease in each country. If you compare with the second, you have less tests, then probably you have a much more people that you did not realize that have gotten the disease. So the numbers should be corrected at this point of time. We cannot go back in time in order to test more, but we do know how to behave in the future. So again, communication, it's a key. But when I was invited to the talk, I was thinking about all of this stuff that we can see in other countries that are in somehow ahead in time. It's like for our southern countries, we are getting the six later, and we have the winter and summer effects later, if you realize. So I wanted to understand the curves in my region where I live, where I work, which is a small region here at the south of here is Santiago, which is the capital of Chile. And in order of population, it's like now 900,000 people. So you have less than a million. And I want to compare what's happening here in comparison with the previous curve that I showed to you. So if you do that and you plot for instance, just the total number of new cases, you will see exactly the same behavior. A first wave that goes up very fastly and then goes down very slowly. If you compute the derivative, you will see exactly the same stuff that I showed you before. A huge peak, then followed by something like that. Here is 0. And then you will have, surprisingly, a small curve going up and down that everyone thought that it was actually the second wave, but it actually was something telling you that a second wave was going to happen, but actually did. And now we have something like that. So it's the same behavior. If you see the conclusions are exactly the same that you can do for all of the other 6 countries. So if we are really paying attention, we should learn something, and we didn't. We behave exactly the same, and we see the dynamics of the disease exactly the same that happened in the Northern Hemisphere. But an interesting question is that here, since I have much more data, I can compute the curves for any age group and decompose this huge curve in smaller curves. Yeah. So I plot down that, and we can see very interesting things happen in the previous wave in comparison with the second one. For instance, if you see here, the most prominent number of cases were coming from the 31 to 40 age, but at the second wave, you can see that it becomes more prominent, the 21 to 30. A much more interesting effect is that the 41 to 50 is pretty much the same. The peak is it's really close one to another, but the 51 to 61, it increases, and now you have like one sort of population, a second type of population. So you have a huge group here from 21 to 40, another group from 41 to 60, but look at closely what's happening with the 30 to 20, which is the blue curve here. It was always very slow, but at some point that's increasing, and it should be continuing increasing at this point. And you have a much more interesting effect here in the 61 to 50 and to 31, that they remain very close, and then have a huge decreases prior to other population groups. That raises to us a question: what's happening here? Why elderly people is getting less the disease than younger people? So in order to understand that effect, we compute the ratio of the number of cases of each group divided by the total of cases of the population at this point. And you will see very interesting effect here. Actually, the younger people, the adults here from 21 to 40 are pretty much the same curve, but the green curve here has a very sharp decrease. The same, but with slower derivative, smaller derivative. It's happening with the 41 to 50. And look at that. From here to the future, the positivity of the elderly people is going down. If we go back to the 0 to 20, you will see that from 5% of the 5% of the positive cases belonged to 0 to 20, and now we are at about 15%. So something happened that changes the distribution of the positive cases among the age of the population. And then you realize, if you understand in order to understand this better, we compute an ARIMA model and see that this was indeed the case. In the last 2 months, you predict that your curve from 0 to 20 should be at this level, but actually you're always above this curve. And the opposite happens to elderly groups. You predict that you have something like that, you have much lower cases, much lower positivity, and the same for the older. So if you think about it, there's two things that you might be understanding here. First is that Chile has a very strong vaccination program that started before March, but the most important part is that it was focused on the elderly. So before March until April, all this proportion of the vaccines are getting for the older people. And younger people started to the vaccination program just in May. So at the very first beginning, you have a strong proportion of the older people getting the vaccine, and then start to the other groups. And that is important because if you come back, you are seeing actually the same in the data. You're seeing that, yeah, it didn't. Oh, I think that I did something wrong here. I'm so sorry. Wow. I'll try to, I don't know if you are hearing me, but I got out from. Yeah. If you're still hearing me, please say something. Well, as I was saying, the vaccination program was focused on the older people, and you see actually that the older people is getting less, is showing a lesser positivity ratio. So that's a very good news. It's actually telling you that even if you're having vaccines that are not from another country, because most of the vaccination here is from the CoronaVac of China, it's actually protecting the people that have gotten the vaccine. So I think that I finished my time, and we can go back to the question at Claudia there.
Yeah, thank you so much, Dr. Christopher, for the detailed information.
I had a small problem at the end, so I didn't know if you were listening to me. I'm so sorry.
Yeah, we could listen you clearly.
Okay, thank you.
Thank you so much, Christopher. So it was really interesting to learn about the COVID-19 waves over time. So a reminder to audience, if you have any question for Dr. Christopher or Dr. Guru, you can post it in the chat box. We'll address it at the end of all the presentation. So with this, we move on to our third presentation. So our third speaker is Dr. Tawfiq Joder. He is a vice chairperson of the Public Health Foundation in Bangladesh, and he is a health policy and system researcher. In his professional life, he serves as a consultant health force in WHO and as an associate professor of global health, Department of Public Health, North South University, Bangladesh. His area of interest include health policy, health system, human research for health, global health, nutrition policy, medical anthropology, mixed method research, implementation science, and psychometrics. So I hand over the floor to Dr. Tawfiq. We look forward to your presentation. Thank you.
Thank you very much. Actually, I'm presenting from Bangladesh, and this is actually the time for the prayer, and the prayer call is going on. I don't know, you can hear me. Literally, I can't hear anything.
Yeah, we
Anyways,
can hear you.
oh, you can hear me. Great. So my microphone is doing well in canceling the noise. So yes, thank you very much, Sabina, for introducing me. My name is Tawfiq Joardar, and I'm basically a health policy and systems researcher, or broadly a public health researcher, and currently working as a consultant and working as the vice chairperson of Public Health Foundation of Bangladesh. So basically, we will talk about the risk communication approaches that some of which I looked closely, or where I was involved closely with some of those activities. I'm sure there are many other risk communication approaches are currently in play in Bangladesh, but we cannot cover everything in the interest of time. So, Bangladesh is actually a South Asian country, very close to Nepal and India and Bhutan. We observed the first COVID-19 case on 8th March 2020, and the first death was on 18th March. And educational institutions were closed on 16th March, and it has remained they remained closed ever since. Interestingly, a general holiday. So mark this term. The government actually introduced a general holiday instead of a lockdown, or in the guise of a lockdown, on 26th March for 1 week or 10 days actually, but they kept on increasing week by week until 31st May 2020. In March, we observed some additional waves, and then it went down a little bit. Then in June, again, it went up. So we are basically in the, I don't know, it's a continuation of the second wave, or is it actually third wave? My previous colleague could actually tell better, but this is where we are. We are actually seeing a very rapid rise in the numbers of the COVID-19 cases, and the government again came up with a lockdown, but this time actually they called it a lockdown. It started in April, and continued in April. Sorry, it's not March, it's April, 5 to 11th April, then it continued actually. Total cases are 866,877, and deaths are around 14,000. In terms of new cases, Bangladesh is actually one of the highest in the world. Yesterday, we had 5,700 cases. But in terms of tests per million, we are one of the lowest. And interestingly and surprisingly, and I should say it's a shame that the WHO RCC guideline was published, the first version was published on 10th January. Then again, the next next version was published on 19th March 2020, but our risk communication and community engagement guideline, not even a guideline, it was a draft. The first draft was just submitted a few days ago on 19th June 2021. I mean, more than 1.5 years after the original guideline that WHO published. So this is the situation. Public Health Foundation and other organizations, I'm sure there are many other organizations who conducted several research studies on or hinging on the risk communication and community engagement issues. So one of the studies was carried out by a colleague, Mr. Rabbani, and he found that it was actually a CAP study, a knowledge attitude practice study. And we found that more than 55% people actually had a poor knowledge, 49% people had negative attitude, and 53 or 54% people had poor practice. And more, lower knowledge and practice were observed in rural areas. And interestingly, when we are seeing this second wave, we are seeing this sharp rise in the rural areas as opposed to the first wave, which was more predominant in the urban areas. And he also found that 73% of the people went outside home during the lockdown, or that so-called holiday, the national holiday. And they went out due to the mainly due to the work, because although there was a holiday, but many institutions, especially the garment factories, were open, and they also went to purchase the essential goods because the government did not provide them with the subsistence support. And this is the picture of Dhaka city in the middle of lockdown. I mean, if you want to call it a lockdown, people are wearing masks. That's a good thing because it's from Dhaka, but if you go outside Dhaka, you will hardly find anyone wearing masks. But the situation is improving, hopefully, but it was actually from the first round of the lockdown. And this is hardly believed that lockdown is going on. So these findings and this picture has a lot to say about how we communicate and what are the problems in our communication. And he came up with some excellent recommendations, like the information must be customized for the specific group of people, for villagers, slum dwellers, town residents. And he identified those groups who are responding differently to these knowledge, attitude, practice questions. And special emphasis should be given to specific groups such as the elderly, females, less educated persons, farmers, rural residents, etc. And the channels should be contextually appropriate, including television and social media, because people nowadays are more and more reliant on those media, unlike before when newspaper was actually the main source of information. Lockdown with should come with a very well planned support system. There should be subsistence support for the poor. There should be a voluntary support group for the people for need. We found that some people actually could not even go to the hospital due to the lockdown in the first round of the lockdown back into 2020. Communication should be very clear. We should not use ambiguous terms like national holiday. We will see in a later study what ramification it had on the general perception of the people. There should be clear guideline on what to do, what not to do, who to consult in an emergency situation. Those were actually not done during our first round of the. In fact, is not done in the second round of the lockdown too. And an arbitrary increasing of the duration is not a good thing. So please consult with the epidemiologists first, like my colleague who presented before, who presented very nicely how you can actually predict the curves, and based on this prediction you should decide how long you are going to have these lockdowns on. Otherwise people will be demotivated, they will lose trust, because they will start thinking that, okay, these people who are imposing lockdown themselves don't know what they're actually saying. And also engaging the religious, cultural, political and other community-based organizations and leaders or agents are very important. And there should be an evidence-informed or evidence-based context-specific risk communication and social behavior change communication strategy. Another approach, the next study, it was actually more like an intervention rather than a study. So our colleagues, very young, energetic colleagues, they carried out some rapid studies based on the research evidence, newspaper articles, calls from anonymous stories in the Google form. So they actually circulated Google forms to share the stories from the people, and based on those responses they identified some incidents of stigmatization. For example, for COVID-19 cases and COVID-19 the families who have somebody suffering from a COVID-19, we found that the law enforcers violated the medical ethics, publishing even their location details in public domain. They put color stickers on their doors. Sometimes some people were even thrown out of their homes while they were actually suffering from COVID-19. Frontline health workers like the doctors, nurses, even the orderlies or the cleaners working in the hospitals, they were requested by their landlords to leave their household. Police officers were perceived as contagious, considering the nature of the job. Traditionally vulnerable people became more vulnerable. For example, the domestic workers, garment workers, slum dwellers. So they also came up with some very useful recommendation for the policymakers, like there should be verified information through authentic sources. If you don't publish good data from good sources, people will actually resort to wrong data, misinformation. Social media monitoring should be there. Prompt legal steps should be taken against the propaganda, falsehood, and conspiracy theories. And there should be, again, an evidence-based guideline, which we have been advocating for long, and is unfortunately still it's missing in Bangladesh. The next study was a vaccine study, a vaccine hesitancy study, and it was among the health professionals. And we found that less than 50% of the health professionals said that they will immediately take a vaccine. This actually took place a few days before the vaccine introduction in Bangladesh. And people were not, even the health professionals who were understandably who have a better knowledge than the general populace, and they were even not convinced to take the vaccine immediately. And some people were identified to delay, for example, the nurses and the females, public sector employees. And the reason for delay, as they identified, were the concern regarding the side effect of the vaccines, and the reason and the fact that these vaccines came to the market in a rapid way. And they recommended that there should be a tailored and targeted strategies for vaccine promotion. Unfortunately, Bangladesh did a very good job in introducing the vaccine at a very early stage, but they could not keep up the steam. I mean, they decreased the age bar, and young people actually went for vaccination who are already like aware. Then suddenly it dropped. Initially, we saw like more than 200,000, even more than 250,000 people taking vaccines per day, which is now 3,000 in a country of 170 million people. Can you imagine? So this is how communication is very, very important in promoting vaccines, decision making, and every aspect of management of a pandemic. Our colleague from Sussex University and another university in Bangladesh, ULAB, University of Liberal Arts Bangladesh, conducted an anthropological study based on content analysis, visual ethnography, telephone interviews, and literature synthesis. And they, I mean, I'm not going into the detail of this slide because it will take long, but rather I will actually describe in a more descriptive way, in a more storytelling way. So initially, the people considered this disease to be a foreign disease. I mean, they thought that Bangladesh is going to escape because this disease is happening due to the immoral lifestyle of the Europeans and the bizarre food habit of the Chinese. Since Bangladeshi people are actually immune from those things, so they are not going to get this disease. Secondly, there was a scientific denial among the scientific community too. Some scientists, even doctors, came to the social media, even the national media, claiming that the COVID-19 is not going to hit. They very confidently said that COVID-19 is not going to hit Bangladesh because Bangladesh is a hot and humid country. There was and then suddenly the migrants were coming. You know, Bangladesh has a lot of migrant workers working in the Middle East, Southeast Asian countries, and a lot even in the European countries. So they started coming back. And unlike Bhutan, like the first presentation that we saw, Bangladesh resorted to home quarantine, very surprisingly. Anybody who knows about Bangladeshi culture, it is a very intimate culture, and anybody will know that a home quarantine is equal to actually no quarantine, because I mean, when these people come in, their relatives will come, they will mingle with all people, they will roam around because they're coming after a long period of time. So it's not going to work. And suddenly it created a lot of backlash in the community, and the community people started to stigmatize those people, you know. And there was a reason, and this reason was actually a wrong policy of the government. It was not the migrant workers are not really I mean, they're less blameworthy than the decision makers. Then suddenly the border people actually came to senses, and they started stamping on the hands of the people. But that's sort of okay so far. but suddenly people started beating the general people, the victims, the people who are coming from outside. And again, the local government again became very local government, and local police became very active, and they started putting red flags on the household of the returning migrants. I mean, irrespective of their disease status or anything. So this red flag became the symbol of coronavirus in Bangladesh for some time, and that was the first incident of formalized way of generating stigma in the community. Then is incident of beating the people, attacking the migrant returnees were on the rise. Infodemics started soaring in the media. Then suddenly the government imposed this lockdown and deployed a very abusive type of armed reaction to the people, which again created a lot of backlash at that time. I mean, they changed that behavior actually afterwards, but initially it was really abusive. Then horrific news items of stigma and fear started coming in the media. For example, attacking and harassing the patients, obstructing the burial of the people who died of COVID-19, then deserting the suspected family members in the jungles, then patients fleeing from the hospitals due to the mistrust of the service providers, and all sorts of things happen. This picture is actually a picture of a local shop which says that the returning migrants are not welcome. They are not allowed to enter in this shop. So it actually gives us the nightmare of the past, when this segregation thing actually. So it's a kind of apartheid sort of activity that were going on at that time. This is actually a picture of people during the lockdown. In fact, the day when the first death was recorded in Bangladesh, people were flocking in to attend the zanaza, the death death of a cleric. And this is a picture from the media which shows that somebody is actually thrown out of the home, outside on home, and this person is actually now living in a kind of in outside in a I mean in a makeshift housing facility. So these things actually came up. And these researchers, these anthropologists, came up with again some nice recommendations at the micro level, meso level, and macro level. And more understandably, macro level recommendations are related to structural issues, the government level issues. Then the meso level interventions are related to the community level, like community mobilization, engagement with the politicians, community health workers, medical representatives, imams or the religious leaders, and increasing the group interaction. And the micro level interventions were more geared towards the individual, like educating the individual to text messages, social media, mobilization, psychosocial counseling of the victims Then this is actually a study that I conducted from Public Health Foundation of Bangladesh, and it was a mixed method study, and we found that we actually tried to understand the level of trust, both impersonal and interpersonal trust. By impersonal trust, we mean that the trust towards the health system overall, and by interpersonal, we mean the trust towards the service providers. And we found that impersonal trust was actually much lower than the interpersonal trust. That means actually people are not trusting the health system or the overall structure of the service provision, and which is evident from a comment from a respondent. He said, so far we have been blaming only the doctors for not giving services. Now we can see how important service management is in coordination with other health actors. Health system cannot be managed by doctors alone. So previously the blame was only on the doctors, but now people started realizing that it's not just doctors. There are managers, there are policymakers, there are even larger decision makers in the community. And we actually measured trust in terms of 8 domains, and I'm not going into the detail of it, but just saying that the major finding was that the fairness That is, discrimination was the major concern that people expressed regarding the health system, and which is also evident from a comment from one of the respondents. And that respondent said, wealthy and the political elites of the ruling party are getting one type of treatment, while the members of the general public are getting something very different. Some managed to get out of the country via chartered flights. Some ministers booked ICUs even before requiring one. Hearing such news, as a middle or lower middle class member of the society, I can't help losing trust in the health system. All facilities are there to protect the upper layer of the society. So this was the common perception regarding the health system among the community. These are a few other findings which I'm not going into in detail for the sake of time, but again, I'm telling the recommendations like the transparency in the data and decision making, free flow of correct directives and information should be there. There should be a scientifically oriented risk communication strategy, social and behavior change communication strategy. Religious, cultural, political, and community-based forces should be engaged, and there should be an explicit policy guideline to promote culture of respect against the stigma and discrimination. But there are some good examples too, like the positive examples. One such positive example was the Corona Resilient Village approach by the Hunger Project. I'm not describing again the detail of this project, but I'm just telling what in the broad things that they have done. From the very beginning, they started communicating to the people that you are not like a victim, you are not separate, you don't need to be stigmatized for this disease. We are all in it together. And they took the volunteers of this organization carried out a 3W campaign, which is like promoting washing of hands, watching the distances, and wearing masks. Follow-up meetings, they conducted follow-up meetings. Then they created behavior change materials, trained the volunteers, met with the families. They conducted the courtyard meetings, then recruited the imams, the religious preachers, priests, and other social leaders to dispel the misinformation. Help the villagers to get tested because they were not comfortable about getting tested. So these volunteers actually helped them to get tested. They connected with the telemedicine services, which the community people were not aware of. And they helped the community clinics. They helped the eligible individuals. They connected the eligible individuals with the government social safety net programs. And they also created a social philanthropy type of activities, like collected foods, money, materials to distribute to the vulnerable families. These are some pictures of this program. Sort of self-explanatory, the things that I just described. So these are some nice pictures showing some of the activities that they perform. And the result of this activity, as they conducted a small study, they found that mask wearing was actually higher among the CRV villages, the blue one compared to the red ones. And they also find that there were higher level of awareness among the CRV members. But there should be a multi-stakeholder effort on coordination. There should be a scientifically based approach to curb the COVID-19 and risk communication. Local government involvement should be there for planning, coordination, and monitoring. There should be community ownership and engagement. And this project should address the economic and the social challenges as well. I'll finish with this last example. This is called the NORM. This was actually a randomized controlled trial carried out in Bangladesh in 600 villages involving 350,000 subjects. This was commissioned by Yale University, Stanford University, and Innovation for Poverty Action. And they found that their intervention, this NORM intervention, which I will describe it in the next slide, they found that the mask wearing actually increased, and it sustained even after the discontinuation of this program. So this means that this is actually a good way, cost-effective way of doing the risk communication. And NORM interventions are more than tripled mask usage, from 13% to 42% after the intervention. And by NORM, they mean that there should be no cost free mask distribution from door to door. So first thing is that to create a social norm for mask wearing, you must first you need to give it free, because it's cheap, it's easy, it's not very difficult technology, is easily available at hand. And Bangladesh actually produces a lot of it has a garment factory, so producing mask is not a very difficult thing. So it should be distributed without a cost. There should be offering of information on mask wearing via video, brochures, and there should be a reinforcement in person and in public. If you see somebody who is not wearing mask, just tell him or her, reinforce the message. And there should be modeling. That is those activities should be endorsed by the trusted leaders, like the religious, cultural and religious people, the local government leaders, the imams, from the mosques, people like them. And this is currently scaling up, being scaled up to Bangladesh. BRAC is doing in Bangladesh. The government of Bangladesh is also trying to replicate these studies finding as a project in urban areas and rural areas. Nepal is doing great. Nepal, there are some organizations from Nepal who are doing it. In India, in Gujarat, Rajasthan, Telangana, Bihar, West Bengal, in Pakistan, Lahore, in Montevideo, in Uruguay, in Mexico. In those places, actually, this intervention is based on the finding from Bangladesh. Actually, this study was carried out in Bangladesh. Now it is being scaled up to other countries. And the lessons are actually very similar to before. Like reinforcement is critical. And social sanctions were sufficient. This is an interesting finding, because you just create shame and awkwardness. That's sufficient. You don't need to actually beat people, engage the police or the other forces. Just reinforce the message again and again. That's sufficient. And you don't need to actually go for a legal sanctions against the people. And local leaders' engagement is very crucial. With this, I end. Thank you for your attention, and sorry for going a little bit beyond my scheduled time. And if you have any questions, please feel free to ask. Thank you very much.
Thank you so much, Dr. Tawfiq, for your interesting presentation and sharing the practical experiences of Bhutan. All those findings and recommendations you share were very useful. So with this, we move on to the Q&A session, and I request Dr. Karma Tengjin to facilitate the Q&A sessions. Over to you, Dr. Karma.
Okay, thank you. Am I audible, Sabina?
Yes, we can hear you.
Okay, great. I'm sorry about the camera. I think the internet bandwidth can be bad, so I'm just keeping it off. Firstly, my congratulations to all the three respected speakers, from Dr. Takal, Dr. Kristenball, and of course, Dr. Tawfiq. I think each of them had their own unique and very, very enriching experience, which was of diverse. So thank you to all the speakers for a wonderful presentation. With this, we'll move on. Before I post my questions, there were some questions in the chat box. So we'll start with the first question. First question is from Max. I think this is towards the question is for Dr. Takal. Can you provide some specific examples of techniques used at community level for communicating risk information in Bhutan? Dr. Kalsar, this question is for you. You can take 2 minutes.
Thank you, Karma. Again, I'll keep my video off, the camera off, because of the bandwidth. Max, thank you for the question. In fact, very pertinent. I could not go into details of how these risk communications were carried out in Bhutan because I was given just 15 minutes. But some of the examples, one of the good examples I can share here is, as I said, the right message by the right person at the right time. In most of the countries, the risk communication is done by the people at the central level through television or a prominent person from one of the prominent hospitals. The directors will come and talk about risk communication to the people. And then we expect that these are taken up by the people. But in Bhutan, it's more of a community-based and people-centered approach. The people at the community level including the health workers who work at the basic health unit. The lowest unit of health facility in Bhutan is basic health unit. And the head of the community are the people who actually talk about the risk communication. How does the transmission take place, and how can this be, the measures can be applied at the local level. So when for the people in the community health worker is more appropriate than somebody like me sitting at the capital and talking about the risk and the community engagement. So however, it doesn't mean that everything is left to them. I do provide them the technical assistance with regard to what they can talk to. And if some innovations are to be carried out, it is not me or the central level people who will tell what that particular community needs to do. The community can take the decision as long as it is appropriate. The central level facilitates it to be implemented. So this is one of such examples that we have carried out, rather than the directive approach where a prominent politician or a prominent physician tells people what to do, but he really doesn't, for the people of that community, he doesn't belong to them. So we actually, the central task force determines whether the messages are correct or not, the innovations to prevent transmissions are correct or not, but these activities are actually decided by the community. So it becomes more of a people-centered and community approach. Thank you.
Okay, thank you so much, Dr. Kalsa. Thank you so much for your crisp answer. We'll move on to next. I think the question is from Sarah. This probably feels, I feel it is for Kristen Ball. I think Dr. Kristen, I think it was a wonderful presentation. We could really appreciate the waves and the utility of the waves if we take it seriously. That's how I think the question is. I think the question is related to how does the face-to-face classes with children or vacation actually affect these waves? I think this is for you. Yeah, Kristen.
Yeah, the two questions was for me. It's hard to tell because I don't know actually all the countries. I do know the Chilean case, which is the one that I understand better. And the vacation periods are actually very close related with these waves. I would like to show you a little bit of the data in real time so we can discuss it better. But as you can see here, at this part of the curve is previous to the vacation, then you go down, then you go up after the vacation period. So somehow what you can expect, what you want to explain there is then when you have vacations period and people start to moving from one region to another, then at the end of that period, you're going to end up with much more cases, and that's something that you can see not only in Chile but in other countries. But I would say that it's much more related if you look the data for Spain or to UK, you will see that the correlation is much more with the winter summer periods. You can see that the waves in one country, it's like 6 months prior or later to the other ones. So you can see some sort of those effects in order to explain this behavior. As for the face-to-face classes, I don't have enough information in order to answer that question. It would be much more a prior belief than something that I can validate with data. And regarding the second question, it says in terms of severity, are also patients less than 40 years are being more affected in Chile? Yes and no. You have to define the severity of the disease, but if you just look at the percentage of use of UC beds, you will see that pretty much 60% of the UC beds at this time are used by people that haven't got any of the vaccines. 30% is people that has not finished the two vaccination program, has only one vaccine, and they need the second doses. And only 10% of the people is without is with the vaccination process, has finished the vaccination process. So there's a strong correlation between the vaccination groups, age groups, and getting a more severe COVID case.
Okay. Thank you, Dr. Kristen. Well, thank you so much for your response. We'll move on to the third speaker. I think there are no questions from in the chat box, so I'll take the liberty to ask one question to Dr. Tawfiq. I think, Dr. Tawfiq, firstly, let me begin by congratulating you. I think with the wonderful presentation, with 4 wonderful studies. And just to get a glimpse of because I strongly believe countries, especially Bangladesh and even in Nepal, I think NGO system is a very strong system. What sort of, if you could share, what sort of role are these NGOs playing in Bangladesh in terms of risk communication, especially during this pandemic? If you could share some briefly, maybe 2 minutes or so. Thank you, Dr. Tawfiq.
Thank you, Dr. Karma. So as you rightly said, NGOs actually play a very vital role in Bangladesh, and it's kind of historical. So in 1971, when Bangladesh gained independence, it was actually a war-torn country, and the government actually had very few resources to actually rebuild, and the NGOs actually came up, and it's actually a is a very good communication between trusting relation between the government and the NGOs, which made it possible. And that's actually the secret. NGOs have been working well. Of course, there may be problems and issues, but there is a good communication between the government and the trust between the government and the NGOs, which helps them work. And the NGOs are very close to the community. Their structure is actually designed in a way they're more reliant on the community health workers. They're more reliant on the community-based volunteers. And that made the community engagement and risk communication easier for them, because it's not centrally driven. It's very much community driven. You don't need to actually do anything from Dhaka. I mean, it's you just give the messages to them, train them, communicate with them, and these people are very well linked up with the community. And there is a very basic understanding that every single community has a resource. This resource is the resource of their network. I mean, there is no community in the world which does not have this resource within itself, and we need to actually tap into that. And that's what the NGOs are doing right. I think they're simply utilizing the inherent strength of these communities to build it up, and where the government actually failed to some extent, but the NGOs worked. But again, I mean, it's not a relation of competition, rather a relation of trust. So I mean, if NGOs are doing something good, either the government will learn from it or help the NGOs to actually go forward. Thank you.
Thank you, Dr. Tawfiq. We just have we have one more question to Dr. Kristen Ball. I mean, in there is a lot of sort of expectation on many more waves, like third waves, fourth waves coming, right? And then I mean, through this the modeling you have created, a mathematical model you have used to explain the first wave, second wave. I mean, how many more sort of a wave do you expect, or how does this actually get affected? Would you like to take this question briefly, Dr. Kristen Ball?
Yeah, thanks for the question. It's a very nice question, because there are some stuff that you have to realize when you work with models. First of all, is that models work are as good as the data that you're providing them. If the data is not good, you're not going to be able to predict very good something. And at this point, all the models are built on data available. But at this point, you know that you have a new variants of COVID. And those variants might change pretty much everything you have been doing. So at this point, you will be able to say what is going to happen probably in the next week. But if you can't try to predict, if you try to predict something in the next several months, you are not going to have enough information in order to sharply say that's going to happen. And that's why this sort of work must be doing all the time and continuously improving. I think pretty much the problem now is that, and a second thing is that when you predict something and you communicate this prediction, you change the behavior of the population. So, like if I say that there's going to be a huge third wave next week, and I say that into the press, probably people are not going to go out as often as they're doing because of fear, and therefore my prediction is not going to be as sharp as I wanted to do. So that's why when you try to understand the data, you have to be very careful what you can say, what you can predict, because you can change the behavior of the population, or and much more if you are saying something that the government is listening, then the government may take different measures and it's going to change everything. So models are good. They can allow you to predict what's going to happen in the future, but in a very short period of time. I would say 1 to 2 weeks, no more, no much more than that.
Yep. Thank you, Dr. Christenbel. Thank you. Thank you so much for the response. We will take the last question, and I would like to invite Dr. Takal sir to quickly give a response to this. I mean, we all know Bhutan is a small in terms of geography, in terms of population. How have we as a Bhutanese, we as a Bhutan, as a country, taken this advantage of being smallness in terms of risk communication, in terms of trying to get to the lowest level of individuals. So 2 minutes.
Dr. Karma, you also know that we are also one of the most difficult countries to travel, right? Though our population is small, it's so scattered that to reach individual is a very difficult task. But having said that, I think one of the biggest assets we have in Bhutan is the well-functioning primary healthcare, where we have the primary health centers up to the lowest level and functioning and well staffed, I should say. The other thing we have is the commitment from the health workers when it comes to managing whatever disease, whether it's an epidemic or when it comes to endemic diseases. The third thing we have, one of the most important thing I should say than all these is the commitment to provide free healthcare services to all the people, right from the throne to the politicians to the governments, whoever comes into power. Having said that, because we have the primary healthcare centers and the people manning their working sincerely, I believe we have been able to reach the risk communication to the people to the lowest level. Where unlike other countries, we have not been able to carry out the survey and find out what is their knowledge, what is their attitude, what is their practice. But the fact that we have been able to contain the diseases and preventing it from spreading in a mass scale shows that I think the risk communication approach we have taken has worked. But again, no evidence to say that, okay, this many percentage of people have knowledge, have changed their attitude and they are practicing. But looking at the practical experience and the evidences that we have been able to contain the pandemic to the localized outbreaks to a very small community and not to the entire community, probably, again, I will use the word probably, has worked, and then it has been successful. Thank you, Dr. Karma.
Thank you so much. Thank you. With this, we have come to the end of this Q&A session of this wonderful webinar. So I would like to again, before I hand over to the logistic team, would like to thank the three speakers for wonderful presentations, and very eloquent and well-prepared presentation. It was worth the evening. Thanks so much. And with this, I hand over back to Sabina for any last-minute announcements.
Thank you, sir. Thank you so much, Dr. Karma, and thanks to all our speakers for the active discussion and very informative presentation. So with this, we have come to the end of the presentation, end of the webinar. So before we wrap up the session, I would like to quickly give information on the upcoming webinar. We have next webinar on July 29 on climate change, health, and small island states. We hope that everybody will be able to participate in this webinar too. So I also would like to inform you that all the PowerPoint slides and webinar recording will be made available in the CIH websites. So with this, I officially announce the closure of this webinar. Thank you, everyone. Stay safe. Have a good day, good evening, good night. Thank you so much.
Thank you.
Thanks to everyone.
Thank you, Sabina. Thank you.